During your OB/GYN rotation, you may not get to see much urinary incontinence or the management of it. And I'm going to give you a talk now on the modern management of stress urinary incontinence. The mechanism by which women are continent is not well understood, but what has come to our understanding, or what has improved, is our understanding of why women don't leak urine with increases in abdominal pressure. And in this diagram, which is from John O'Delancey, who has done much work in this area, the urethra, which is here, is surrounded by a hammock or a sling of pubo-urethral tissue, which at times of coughing and intra-abdominal stress, it causes a dynamic kinking of the urethra, which seems to keep women continent. For many years, large procedures such as the Birch-Colpus suspension, which was first done in the 1960s, and with the modifications of it, were used to treat women with urinary incontinence. And what those procedures attempted to do was to create a permanent kink in the urethra. But unfortunately that led to voiding dysfunction, and many women went from having stress incontinence ultimately to having overactive bladder, and that often happened to 20 to 25% of these women. In the mid-90s, the two clinicians in Scandinavia, Peter Papapetras and Ulf Ulmsten, came up with a replacement procedure for the sling underneath the urethra, the pubourethral sling. And they designed the tension-free vaginal tape, and it was widely used for many years. And unfortunately, there were a few complications with this, which included perforations of the bladder, formation of hematomas in the retropubic space, bowel perforations, and bleeding from large vessels in the retropubic space. And to avoid these complications, a new approach was designed by Emmanuel Delorme in Belgium, and he proposed that the needles that are used to pass the new sling are not passed behind the urethra, but actually were passed out through the obturator membrane and muscle. And the transobturator approach to passing the tape was then invented. I'm going to talk about the procedure and how it's done, but I'm going to go through some of the anatomy behind this. The needle insertion starts along the medial edge of the ischial-pubic ramus, or the inferior ramus of the pubis, just below the insertion of the adductor longus tendon. And you don't actually want to put the tape through the adductor longus tendon, because that will lead to pain. And then it passes around the ischial-pubic ramus, through the skin, through the adductor longus tendon, through the obturator externus muscle, through the obturator membrane, through the obturator internus muscle, through the periurethral and pelvic fascia, and through the little vaginal incision. I'll explain that more graphically. The hammock support, the hammock concept of urinary continence was described by John O'Delancey, and that downward force against that hammock, or kinking against that hammock, keeps women continent, and that's what has led to the advent of this procedure. So as I described earlier, this is the John O'Delancey diagrams of the continence mechanism, where the tapes are passed is through the obturator foramen. The vessels and nerves are quite posterior in that, so the damage that can happen to those structures are minimized. This diagram also shows that the TVT and the spark procedure went behind the pubic bone, whereas the new transobturator approach is slightly lateral to that. Just to show you how this is done, the patient is prepped and placed in lithotomy position with the legs well flexed, because that will actually carry the obturator vessels up out of harm's way, and the procedure then is performed. It can be performed under local anesthetic, but the patient is in an awkward position for 20 to 30 minutes, and I think many of our patients prefer either to have a spinal or a general anesthetic for the procedure to be performed. And again, the other lines here are showing the direction through which the TVT previously would have travelled, and now we're seeing the transobturator direction for insertion of the tapes. This is a diagram showing the the design of the inserters for doing this, and they have a helical design which helps get the suture, the device through the obturator membrane. And again, patient is prepped, local anesthesia is put into the obturator foraminal area. The incision that's going to be made there is around the level of the clitoris at the lateral border of the labia majora in the vagina. A small little incision is made following the insertion of local anesthesia, and this shows the small 1 to 2 centimeter incision that is made just a few centimeters behind the opening or the external urethral meatus. A small dissection is made then in the vaginal wall, out laterally in both directions, right and left. And these little areas, these little dissection areas, are developed a little bit digitally. Then, using the finger, you can actually feel the lateral border of the bone, and it will delineate where the foramina are, and you can do that then digitally. And a small incision is made laterally, and the tape then is passed using the needle out into that area, and you can see that here, that the needle emerges. And the diagram again just demonstrates that, where the urethra is and where the tape then is inserted in underneath the urethra, behind the pubic bone, and out through the incision. And the same thing is done on the far side. The tape is covered, most of the tapes are covered with a plastic covering which allows easy movement of the tape, and the tape then is tensioned with the full bladder and the patient either coughing, or if asleep, full bladder with suprapubic pressure, and the tape can be just tensioned just right so that continence is optimized. The outer sheath is then removed, the mesh is shortened, and at the end of the procedure the small incisions are closed. So what are the overall results? Well, the initial results have shown a cure rate of over 90%, which is very good for any surgical procedure. And overall, these kind of tapes seem to mimic the pubourethral ligaments. There isn't a major risk of bleeding with these. There's no bladder or bowel perforation risk with this, because the needles are not going into the abdominal cavity. Patients do like the procedure. There may be less voiding dysfunction afterwards, and certainly they're as good as the other tapes. So hopefully that gives you an outline of what we see with respect to the modern management of urinary incontinence. Thanks for your attention.